invited Dr. Stovitz to come here about, I don't have a lot of control. So Dr. Stovitz, we're excited that he came here. Dr. Dupre initially recommended him a couple months ago. I think we got an email with quite a bit of praise, and so we're excited that he's in the show. So he's talking about obesity and heart failure. So thanks for tracking him all the way from the other side.
Thank you. My pleasure, and I guess the thing doesn't work here. There we go. Okay. So anyways, I'm in the Department of Family Medicine, but I practice mostly sports medicine. I also have a clinic in what's called lifestyle medicine. So we try to treat obese patients who we don't use medications, and we're not the surgery clinic. So, but we see people every Tuesday morning. We try to help them with diet and exercise. I've had a few of Dr. Dupre's patients, one who has genetic hypertriglyceridemia and hypercholesterolemia and was having side effects with medications. And anyways, she lost quite a bit of weight, and her lipids are at the level they were when they were on the medications, but without medications, so life's good. So we have our successes, we certainly have our failures. But if you have obese patients and you and they don't want medications or surgery, send them my way. And also, I would love to have a link to a cardiologist where for our patients who need stress testing, certainly not everybody I see, I send for stress testing, but there are certain people that I want to prescribe exercise. And if they have chest pain, I'd love to have a number to go to. So that's that. But I'm not here to talk to you about that. I'm here to talk to you about the obesity paradox. Can everybody hear me okay? Okay. So I've been here at the university for like 17 years and been a practicing physician for 20. And again, I do sports medicine and family medicine, and I also have a master's in clinical research. I work with Sue on a few papers, and it's a pleasure to be here. So is everybody here fellows? Any attendings here? No? Okay, good. Because the attendings are screwing up, and you guys can change the future. So here we go. I'm sure you've all heard of the obesity paradox, right? So it's a very, very, very popular topic. There's many doctors who publish on it. There's 38 articles in PubMed right now with the obesity paradox in the title. The person who publishes the most is a doctor in Louisiana by the name of Lavie. He trained at Mayo Clinic. He has over 600 publications. I just looked him up. He's got an H factor of 58. Very prolific writer. He's got a book out about it. So it's a common topic. There are publications on this coming out constantly. Somebody here help me out. It's kind of not that important what the specific definition is, but somebody throw out what's the definition of heart failure? I was going to look it up, but then I was like, well, that's stupid. I'm going to cardiology. So how would you define heart failure?
Yeah,
Is there an ejection fraction cutoff or no ejection fraction cutoff? So it's based on
inability of the heart to basically give the circulation. That means that we get low or
okay. So the heart doesn't pump sufficiently. Effectively.
I remember Dr. J. Cohen when I was interviewing here for fellowship about Scott. He said, you know, he was not happy what the definition is. I think in the end he decided that elevated pressure in the heart that leads to symptoms is basically healthy heart.
Heart failure. Okay. And throw out some causes of heart failure. What are causes of heart failure? This is not a quiz. This is so I can learn. I'm not like pimping you guys. This is like helping me. So I'm not pimping. What? Okay, so ischemia. Infection. So can we say genetic? There could be some genetic causes of that would cause these type things. And then, pardon me? Hypertension, ischemic hypertension. And it's hard to know what's cause and effect here, but I'm going to throw out obesity, which of course is a risk factor for hypertension, is a risk factor for ischemia. Obesity is probably not a risk factor for infection. Obesity is not a risk factor for genetics. We all have genetics. Okay, so we've got a few things. So if you saw this guy right here, and he came into your office and he had heart failure, and you thought about what his cause was, you'd probably think maybe cigarettes, maybe obesity, okay? Remove the boxing gloves, but keep the same body. So forget the boxing gloves. This is Robert De Niro in the same movie. If you saw this gentleman come in and he had heart failure, you'd think there's something else going on, right? Okay. So what is the obesity paradox? The obesity paradox is the finding that those with heart failure and other problems caused by obesity do better when they are obese. So from an article, this is from 4 days ago, from Dr. Lavie, despite the adverse effects obesity has on cardiovascular risk factors and its association with increased incidence of most cardiovascular disease, including hypertension and coronary heart disease, and for heart failure itself, many large studies have demonstrated the powerful obesity paradox in cohorts with established heart failure. In fact, the presence of overweight and obese, at least mild, appears to confer a better short and intermediate term prognosis than in leaner counterparts who have similar degrees of heart failure. Let's listen to, let's see, you said Alt-Tab. Alt-Tab. So we're going to listen to Dr. Lavie. The first one we're going to listen for about 1 minute and 10 seconds. This is him being interviewed on a podcast, so in his own words.
Carl Lavie, his book is The Obesity Paradox. Dr. Lavie, welcome to HXP.
Thank you for having me.
So, Dr. Lavie, if you could just briefly get into your background, your education, help us understand who you are.
I'm a specialist in cardiovascular diseases. I did medical school at LSU in New Orleans. I did my medicine residency at Ochsner in New Orleans, where I am right now. And I trained in cardiovascular diseases at the Mayo Clinic in Rochester, Minnesota, before returning to Ochsner about 25 years ago. I am the author of over 800 medical publications and 3 textbooks, including the Obesity Paradox book. The other 2 are books for medical specialists. And I'm a frequent lecturer, particularly in areas related to the prevention of cardiovascular diseases.
Okay. So let's dig right in. I mean, would you call this book controversial?
I think it is controversial, and in some ways, I think that the research that my colleagues and I have done during the past 15 years has been, in a way, revolutionary. And I think the results have been somewhat confusing. They've been surprising to me as a doctor, and in some ways have turned conventional wisdom on its head. But basically, our research during the last 15 years has pointed out that fat is not always the devil. And
Okay, so he's not from Minnesota, we got that. That's not the point of the talk. So here's the obesity paradox in his own words.
And certainly, overweightness and obesity are associated with increased risk of most cardiovascular diseases. But despite this evidence, my colleagues and I, and others, have many major publications in some of the world's most prestigious medical journals demonstrating a very powerful obesity paradox, meaning that overweight and obese with these same heart diseases often have a considerably better prognosis, sometimes 30 to 50% lower mortality rates then do their lean counterparts with the same heart diseases.
Okay, so that's the obesity paradox. So, what's a paradox? A paradox is a statement that contradicts itself. It's illogical. Doesn't make sense. There's something called Zeno's paradox. Sue, this is my favorite book. Have you read this? How Not to Be Wrong, The Power of Mathematical Thinking. So, do you like it? Yeah. So Zeno's paradox in getting to the ice cream cone. So you want to walk across the street to get to an ice cream cone. To get there, you must first walk half the distance to the ice cream cone. And once you're halfway there, you then must walk again halfway to the ice cream cone. And once you're there, you must walk halfway to the ice cream cone. So you actually mathematically never get to the ice cream cone. Because wherever you are, you have to go halfway there. But we know that we actually get to the ice cream cone, because we've all walked across the street to Sebastian Joe's and gotten the ice cream cone. So that's a paradox. It's illogical. I used logic to show you you don't get there, but you know that you do get there. That's a paradox. With the obesity paradox, it is true that obesity leads to morbidities, including heart failure. It's also true that among those with heart failure, those who are obese do better than those who are not obese. But it's not a paradox. In fact, the reason that both statements are true are due to logic. It's completely logical. It's not a paradox. So he published one of these things, so I wrote this letter to the editor entitled, True and True, but Not a Paradox. So he published in Heart on a meta-analysis and a commentary, and he describes two hypothetical patients with heart failure. One has a BMI of 23, and the other has a BMI of 32, who is obese. And if you ask about their prognosis, the meta-analysis will show that the obese patient does better. However, this is just like if you take low birth weight babies. If you take low birth weight babies, those who are born to mothers who smoke do better than those who are born to mothers who don't smoke. Why are babies low birth weight? I'm talking really low birth weight. Either because the mother smoked or because of reasons other than smoking. So it is misleading to imply that obesity is protective. He never goes on to say it's protective. He just says it's fascinating, it's revolutionary, we can't understand it, whatever. He doesn't say it's protective. And in fact, in the obese patients, those who lose weight do better than those who don't lose weight. This is all dependent upon the word conditional, which is an epi term that I can't stand, but that's the issue, okay? The non-obese subject with coronary heart disease must have contracted coronary heart disease from factors unrelated to obesity, such as genetics or infectious disease. The apparent obesity paradox occurs because of confusion with the groups being compared. The comparison is not between obese people and non-obese people. The comparison is between people who have coronary heart disease due to obesity and people who have coronary heart disease due to causes unrelated to obesity. The conclusion is not that obesity is protective, but rather that there are other causes that are more serious. Period. So, to explain this a little more in-depthly, you have to use graphs. I struggle with these. I work with somebody closely who loves these, so I spend my life working with these. So we have this state, and this state is called heart failure, and then we have these two conditions, and we have the outcome, which is death. And we have to figure out what causes what. And if you don't do this, you get confused and you think that obesity is protective. But I will prove to you that it's not. It's just logic, but it appears to be a paradox, and it's hard to say the terms in normal English, so I will ask you to help me. These are my best guesses, my best estimates. One, if you are comparing two causes of an outcome and you condition on an effect of those causes, then you may bias the comparison. Way too jargony, but that's the best I can get Ian to speak it, and that's probably the best, I don't know, Sue. So what's a synonym for conditioned on? My synonyms are given that, or among those. My wife added starting with. So the key thing is among those with heart failure, those who are obese do better than those who are not obese. Sue, how would you help me out with that one? So conditioned on means given that you have heart failure. Now we're doing the comparison of obese people with non-obese people. So among those with heart failure, who does better? That's the question. Okay. The reason that the whole comparison gets flown up and seems like a paradox is that we link the comparators. And this is called collider stratification bias. And that's way too much jargon for me, okay? So another term for collider stratification bias would be competing causes. Two groups of people, those with A and those without the A, and those without A have something else. Help me. I don't like using terms like collider stratification bias. I don't like using terms like conditioned on, but it's simple logic. If anybody, okay, so here's the comparison. You must understand the comparison, and you must understand collider stratification bias. This is the comparison, obese versus non-obese. However, it is conditional on state E, which is heart failure, or he does the obesity paradox for many things, hyperlipidemia, other things. And the problem is that this state over here is an effect of the comparators. So they both cause this. So when you condition on this, you link these two. If you have obesity, you don't have these other things. If you have these other things, you don't have obesity. That's what I'm saying. I'll show you why in the next slide. I think it's the next slide. Yes, collider stratification bias. When two variables that are unassociated become associated due to statistical conditioning on the third variable. So the man who made this famous is Judea Pearl. And his famous metaphor, which we could think of others, but this is the one he uses, and this is the one that gets cited, is that imagine that you had automatic sprinklers that go on and off without regard to the rain. They just go on and off. There's no association between the sprinklers and the rain. There's no sensor. There's no person turning it on. The sprinklers go on and off at a set time, regardless of rain. They're unassociated. Now, we have wet grass, we have sprinklers, and we have rain. If you condition on the grass being wet, the grass can only get wet from two ways, either the sprinklers or the rain. Then the sprinklers and the rain become associated. If it's not raining, the sprinklers must be on. If the person's not obese, they must have a genetic defect. If the person's not obese, they must have an infection. Which, well, they have a reason, they have heart failure. They have it from some reason. The reasons are either obesity or causes unrelated to obesity. So this all seems techie. I actually, I'm going to step back because I'm getting some glazed eyes. I want you to think about when you see a patient in your office. And I'm going to now say heart failure is a low ejection fraction, just for the sake of argument. So you see somebody in their office, and they have an ejection fraction of 25%. And they're 530 pounds. I would assume that you say, dude, it's your obesity. You got to lose weight. Let's take another person, 40 years old, physically fit, in good shape, normal BMI, their ejection fraction is 25%. You're evaluating for sarcoid, you're evaluating for other things, right? Because it's unexplained why they got the obesity. Am I painting a straw man, or is that reality? Yes.
How do you appreciate this from confounder?
This is a confounder. Yeah, a confounder is a cause of the exposure and the outcome. The exposure, the problem is, the reason I'm using the term confounder is then you're assuming that the exposure is heart failure. And that's where that's where you get screwed up. Because the issue is not, does heart failure cause death? But that's what people think it is. If it was just heart failure cause death, you would need a control for the confounders, which would be obesity, infection, genetics, because they cause heart failure and they cause death. But it's not. But the exposure is not heart failure. The exposure is obesity. The exposure is the causes unrelated to obesity that cause heart failure. And that's where we get confused. How am I doing, Sue? Yeah.
In effect, what he's arguing is that obesity being an acquired, non-infectious, non-genetic condition presents a better prognosis with regard to phenotype heart failure because it's a so-called self-acquired condition, or it's not as potent of a adverse physiologic effect as those of that being other conditions.
I would say, I don't know whether he argues that.
Well,
That's what's occurring.
Right. That's what, he doesn't argue that. He's trying to sensationalize it to make obese people feel better. I mean, that's where I think there's marketing for next time. He can say, he can say, look, it's okay to be more obese because, there's a part of it is...
It's worse than Louisiana because of other issues that shouldn't go on tape, but... yeah.
One of the logical things we could take the subset of people who say have amyloidosis, for example, and compare obese people to that. That would be more convincing. Better.
Correct. I would completely agree. And then you could say, among people with heart failure and amyloidosis, those who are obese or not obese do better. Yes. Yeah.
So, generally in heart failure, we have two subsets. One subset of those people where the heart failure is so severe that the body itself is producing famous factor alpha, interleukin 6, and those can cause cardiac arrhythmia. So that's what tends to worse prognosis, not because of the obesity per se, but because of heart failure is worse. In those patients, we're feeding to make them eat more to gain weight, because that will help us with actual synthetic heart failure. Now, the other subset of patients with preserved heart failure preserved EF, they get the syndrome of heart failure simply because their heart is low to fit, which can be caused by hypertension. Those patients typically do not get, their mortality is not as bad as patients with obesity. So obesity probably plays more contribution.
I agree. There's many ways to phrase this. I mean, I agree. So anyways, I wrote this one, true and true, but not a paradox. And then he said, no, there was no response. And then there's this other editorial. The obesity paradox is not a paradox. Time to focus on effective treatment. And so the writer writes, I recently read the editorial with interest, but also with disappointment. My disappointment is because several papers from different authors have illustrated the reported relationship between obesity and survival from heart failure occurs because all of the observational analysis suffer from a very serious bias if one is exploring causal effects. There's Jay Kaufman and McGill, Preston and Stokes, and then there's this letter to the editor, which was mine, that Lavie didn't reply to, and the author says, I look forward to future academic efforts towards best treatment practices rather than repeating a theory that promotes unnecessary confusion. So this is not meant to be personal. This is meant because they're coming out, I'm not joking, monthly in Journal of American Cardiology, JACC, and Heart in very, very prominent journals. The one that I quoted at the start that came out 4 days ago, we were about to write a letter, and then I looked on the editorial page about what you do to write a letter, and all letters must go through the editor-in-chief, who's Carl Lavie. So we didn't submit the... So, in summary, heart failure and other morbidities caused by obesity are devastating for individuals in our society. The fact that among those with these conditions, those who are obese do better than those who are not obese is not a paradox. It is logic and it is easily explainable. Labeling it as a paradox diverts attention from where it should be focused, on decreasing causes of heart failure and improving treatments. Simple message. But worth my time to find it over, and I hope worth your time. Yeah.
Could you, if we have a few minutes, do you mind spending some time on what it is you do in your weight loss clinic? I mean, just because out of curiosity, because I think that's something that maybe some minor points that we could get some pearls from study. Some of the challenge and you see a lot, particularly with the advent of HFpEF and the syndrome that also get a lot of referrals for obese patients with
So what we do in our lifestyle clinic is they meet with a nutritionist for probably 45 minutes, 50 minutes. We don't have a diet. We don't have a plan. There are many plans out there. If they work for people, go use them. That's great. We try to figure out why people don't do well with those plans. It often, those plans are expensive, they're too rigid, whatever, okay? They also meet with me, and I'm a sports medicine doctor. So when I did stress tests, I don't do stress tests anymore, but when I did for the Look Ahead trial, and I would ask the people to get on the treadmill, and I'd say, anything gonna get in the way of you walking on this treadmill for this study? And the questions were mainly geared towards, are you gonna have chest pain or are you gonna have shortness of breath? 9 out of 10 of them said, not that. Well, what's bothering you? My knees, my ankles, my hip, my back. So I see people with those problems too. So I may inject their knees too. Now, it'd be great if I worked with a psychologist. I did for a while. The visits were now taking 2 hours. It was too laborious. We do refer to psychology if we need to. It would also be great if I had an exercise physiologist, but I don't have that, but I do work closely with physical therapists. So I refer for physical therapy to treat their back pain and try to get them more active. If they're looking for a quick fix, looking for surgery, don't send them to our clinic. They'll be disappointed. We have been tracking them. They lose about 1/8 of a pound, 0.8 pounds per week on average. So we have some successes, others not so much. The weight loss we're seeing, my own theory is probably the initial weight loss is diet, and then sustained weight loss has to have an exercise component. Yeah, usually about every 6 weeks. You know, it's funny, I mean, I don't want to see people who are doing well that much, and some people get kind of, like to come in. And sometimes they're like, BMI is now at under 30. I'm like, you can do this. It's okay. But I'm not, I don't get paid. I get paid a salary, like I don't, if they show or not show. So I don't have any financial incentive. I see about, Should we see them more often? Yeah, but that would break the bank of our country. I try to do things that are sustainable from a financial thing. Yep.
We have the subset of patients that we struggle with. Those are the patients that are going to be top ones. Their BMI count point 35 and that much higher than that. And before that, when people do it, they need to lose weight. And we try to see them in clinic, but as much as we try, those patients end up without consequence to weight. Are there at the university, and do you see those type of people where you really have to lose weight to be able to live, not just for your own?
So, I mean, we definitely get some people who say, I need to get my BMI to such and such for a procedure. I don't know where those such and such cutoffs come from, so I don't pick a specific weight that we target. What we do target is a 5% weight loss in the first 3 months. At first, I was opposed to picking a number like that, but it actually does normalize people fairly well. So if people are 400 pounds, that's 20 pounds in 3 months, which is about 1.5 pounds a week. The average patient we see is about 250, 300 pounds. It's about 1 pound a week, 12.5 to 13 pounds, so about 1 pound a week. We're not a quick, if somebody wants to come in, doesn't really want to work out, but needs to lose 40 pounds, they should probably go to the medical weight management program. I mean, I'm happy to see them if they really want to work with us, you know. You had your hand up first. Yeah, I would totally do a combination of strength training and cardio. I don't have a, it's so individual, but I've learned so much from seeing people. So for instance, if I'm seeing a 25-year-old who's obese but can get on a treadmill and be on the treadmill for 30 minutes, and they do it 5 times a week, I tell them to pick a distance that's farther than they're going. Because so let's say they're going 2.5 miles. I say, well, I need you to go 3. So there's 2 ways to go 3 miles if you're going 2.5 now. You either run faster or you run longer. And so people can choose which one they do, okay? Some people I see, if I can get them to walk down the hallway of their senior living center 4 times in a day, it's a huge success. I mean, I'm sure you see those kind of people too. So I apologize, I don't have, but I do feel strength training is underemphasized, especially for our diabetic patients. You know, so we kind of do a combination of both. I think a personal trainer is helpful on occasion and a home exercise program. Some people can't afford it. If I had to invent the world, we would have those within our office and satellite people, but I don't control the world. Yeah? No, and I think it's very idiosyncratic, and that's why I think these diets work for a while. So my own theory is as follows, that the country did eat a high-fat diet. We switched to this high-carb diet. Those people who were then still obese did well on a low-carb diet. Because they're in a society with a high-carb diet, and they're still obese. Okay? But the box of pasta is 6 portions of pasta. Okay? I eat that in a night. Okay? I don't have a problem with carbs. Okay? So I'm not going to show up and then do well on a low-carb diet because I'm doing well on a high-carb diet. So I don't know that there's any, you know what I mean? I mean, it depends. Whatever got you there, you need to make a change. Yeah. Yes? Oh, we're back to heart failure. Yeah. Okay, go on. Sorry.
They have, like, people are obese because they eat fried food and fat, versus people are...
I've never seen it stratified with outcomes for that, no.
Usually it's a high carb,
Yeah.
I call it fat. Very rarely you have low fat.
But if I had to get people to do one thing, it would sort of be to increase awareness, you know, body awareness. You get to be my age, you start to realize that with a muffin you feel kind of sluggish, and with some protein you don't. But very few people are in touch with how food makes them feel. And fortunately, healthy foods make people feel more energetic. So we don't do strict calorie counting. We don't do, and I know that's frustrating to some people. There are so many programs out there that do that. And if they work for people, that's great. I'm not here to put Weight Watchers out of business or anybody else out of business. If they can count calories and do the Seattle Sutton and do all this stuff, all the more power to them. It's just calorie counting. Obesity is not fair. Two people can have the same food and exercise the same, and one gains weight and one doesn't. Just have another, I'll leave you with this one, and then I'll do the abnormal thing of ending early. So I just thought of this other fun example to maybe hone down this idea that I presented that the obesity paradox is not a paradox. So, so I'd like to prove to you all, I'm going to prove to you that hard work and frugality, meaning not spending money, are not beneficial for your bank account. What do they tell you? No, so by the way, this has nothing to do with the stock market. This has nothing to do with the stock market. This just means in general, working hard and not spending money are not beneficial for wealth accumulation. And I will prove it to you. We're going to design a study, and we're going to take young adults conditioned on a large amount of money. I put 500,000, you could put 300,000. They've got a lot of money in the bank. They've got $300,000 in the bank. And now we're going to break them out into two groups. One works really hard and saves money, and the other group doesn't work at all and spends money like it's going out of style. Who has more money? I will prove to you that that's not correct. Who else has a theory? Which group has more money? I failed. I am not worthy. Those who work, okay, conditioned on having $500,000. Here are the hard workers. They can flip burgers. They can do coffee beans. They can be up late at night. They cannot spend money. And here are the people who don't work hard and who spend like crazy. $300 million, 25.7 million, 3.3 million. This guy who told the flight attendant that he could buy the plane and she should stop bugging him. Paris Hilton's brother, Paris Hilton. How do you get $500,000 if you don't work hard? Trust funds. There are two ways to get a lot of money. You either work hard or you're given the money. There's only two ways to get it. I mean, I guess you could steal it, you know, but we're not talking about that. So there's two ways to get to a certain level of money. Either somebody gives it to you or you earn it. The people who earn it get just above that level. Just like the obese people with the heart failure. If you weigh 500 pounds and you have super severe heart failure, you're not living anymore. So you're not part of the study. The obese people have just crossed over into the heart failure thing. The genetic sarcoidosis, whatever levels you guys were talking about, they're really sick. They got a bad problem. So who has more money? It's the people who are given the money and who are spending it like crazy. Not the hard workers, because we conditioned on a certain level of money. So there's Coca-Cola behind some of that stuff. But we don't have to go there. So that's the Louisiana one. Dr. Duvall, what do you think?
I It's hard to think about. I mean, it's sort of tough. I mean, I remember all my experience when our friend Dr. Shahar was here. We talked about that all the time.
And the problem, oh, sorry.
Yes, and the DAGs, what they call them, the graphs. Nobody, I don't know anybody who really does them, honestly, but you should. Yeah, Rebecca does, that's true.
Who,
One of our
Rebecca?
heart failure docs, Dr. Coswell does them.
Okay.
Always, yeah.
I mean, there's a theory that all statistical analysis in the stats, in the methods should have a DAG.
Yeah.
This is what these were the assumptions we made.
Yeah.
It would be easier for the novice statistician, these are actually potentially look through.
Right. And the key thing is that two things are pointing at each other, and you control that thing, meaning you say they either have it or don't have it. You've all of a sudden linked these two items. That's all you have to understand. There's two reasons for the graph to get wet. But it is hard. My life, aside from patient care that I like and my family who I love, is spent trying to translate these terms that I find very difficult into language that other people can understand. And I struggle with it, and I can understand why people struggle with it. I spend a lot of time.
Spend a lot of years thinking about this stuff, I know.
Yeah, we need to use words that are part of the English language and examples that people can understand. Yeah, there's a hand up in the middle.
Oh, this something
I think that's
not
different.
necessarily.
Yeah, that's not conditioned on that. I mean, it's conditioned on living in France, but I don't think it's the same thing. I think it's that the French have rules about it, and they don't, and they well. Well, thanks very much for